Welcome to the deep dive. Today we're doing a really focused session for your MSRA revision. We're digging into dermatitis herpetiformis.
Yep, DH.
Our goal here is simple. Cut through the noise, grab those high-yield points, and make sure they stick. And honestly, the biggest thing right off the bat.
It's got to be the Coeliac link, right?
Exactly.
Yeah.
That fascinating, absolutely undeniable connection to coeliac disease.
It really is fascinating because you're not just looking at, a skin thing on its own.
Right.
It's a perfect example of how something starting in the gut, triggered by diet, even can show up so dramatically on the skin.
Okay, let's unpack that then.
Right.
What exactly is dermatitis herpetiformis? What are the sort of core definition points we need?
So at its heart, DH is a chronic autoimmune blistering skin disorder. That's the formal bit.
Autoimmune.
Yeah. And the key feature: intensely itchy skin lesions. They often start as little bumps, papules, but quickly become vesicles, then blisters. But the absolute cornerstone, the thing you have to remember, is that super strong link with coeliac disease.
You really can't separate them.
You can't. Think DH, think coeliac. And mechanistically, it involves immunoglobulin IgA getting deposited in the skin, specifically the upper dermis.
Okay, so pulling that together. Autoimmune, right? Itchy blisters, very itchy, IgA deposition, and that massive coeliac link.
Nail those four and you've got the core definition.
Got it. That's the what. Now the why. Where does it actually come from? What kicks this whole thing off?
Well, like we said, it really boils down to gluten intolerance and coeliac disease. That link isn't just like a casual thing, it's fundamental.
How fundamental are we talking?
His stats are pretty stark. Something like 80% of people with DH will have those classic coeliac changes on a gut biopsy.
80%. Wow. Even if they feel totally fine, gut-wise.
Exactly. Even with no obvious gut symptoms at all, which is why sometimes DH is actually the first thing that flags up underlying coeliac disease. It's the skin rash that gets them diagnosed.
Huh. So the skin is shouting while the gut is quiet.
Pretty much. The immune reaction involves these IgA autoantibodies, and they specifically target enzymes called transglutaminases. Tissue transglutaminase TTG, that's the main one.
Okay, so eating gluten, if you're susceptible, triggers this IgA response against TTG.
Right. The body makes antibodies against something it shouldn't, all set off by gluten.
And somehow, these antibodies, which we think of in coeliac hitting the gut, end up in the skin for DH patients.
That's the thinking. Tissue transglutaminase is mainly in the gut, yes, but there's a related form in the skin too, so maybe there's some cross-reactivity.
Oh, okay.
The immune system gets a bit confused, sees gluten, ramps up the IgA against TTG, and some of that IgA finds its way to the skin and deposits there, causing the trouble.
Right. A kind of mistaken identity by the immune system triggered by gluten.
Okay. And just thinking, memory aids, we've got D for dermatitis.
D for diet, the gluten-free diet.
D for Dapsone, which we'll get to for treatment. And definitely need to remember that IgA and TTG antibody link.
Yeah, the mnemonic could be useful. So who's most likely to get this? Are there specific risk factors we should know?
Yeah, definitely. Family history is a big one. If DH runs in the family, your risk is higher. Suggests that genetic link.
Makes sense.
And obviously, if you already have a diagnosis of coeliac disease, that's a major risk factor too. It all ties back to an underlying genetic predisposition, often involving those HLA genes linked with coeliac.
So it really hammers home that inherited coeliac connection.
Yeah.
Runs in the family, or you have coeliac yourself, your risk is up.
Exactly, not just random. There's usually that backdrop.
Okay, this is where it gets really interesting for me. The pathophysiology. How does eating gluten actually lead to skin blisters? Could you walk us through that process a bit more?
Sure. So it starts with gluten consumption in someone who is genetically prone.
Right.
Their immune system, especially in the gut, starts churning out these IgA antibodies, particularly against tissue transglutaminase, TTG. Then, for reasons we don't, fully understand every single step of.
It's complex.
It is. But these IgA antibodies may be bound up in immune complexes. They travel somehow.
From the gut to the skin.
That's the main theory, yes. They circulate and end up depositing in the upper dermis, right at the junction between the epidermis and dermis.
Okay.
And they deposit in this specific granular pattern. Once they're there, they act like little flags.
Flags for what?
Flags for inflammation. They trigger the complement system. They pull in inflammatory cells like neutrophils. Basically waving a red flag saying, attack here.
And that attack causes the damage.
Precisely. This intense local inflammation messes up the structures holding the skin layers together. It's like the glue gets weakened.
Leading to the blisters.
Exactly. That disruption forms tiny vesicles first, then the bigger blisters you see, and the itch. Probably all those inflammatory chemicals irritating the nerve endings nearby.
Okay, so gluten, IgA deposits in skin flags for inflammation. Inflammation breaks down skin adhesion, blisters plus itch. Got it. Much clearer.
That's the core mechanism to grasp, yeah.
Now, DH sounds pretty distinctive, especially with the itch and symmetry, but it's not the only itchy, blistery rash out there, is it?
No, definitely not. And that's crucial clinically and for exams.
So what else should be on the differential diagnosis list?
Well, the sources give a good list. You've got things like eczema, obviously, if it's very itchy. Erythema multiforme can cause blisters.
Okay.
There's herpes gestationis. That's a pregnancy-related blistering thing, rare. Linear IgA bullous dermatosis. That one's important because it also involves IgA. But the pattern's different, and crucially, it's not linked to coeliac.
Right, key distinction.
Also need to think about neurotic excoriations, basically scratching from any cause of severe itch. Papular urticaria, like bad insect bite reactions. Scabies, always think scabies with severe itch. And transient acantholytic dermatosis.
Okay, that's quite a list to keep in mind.
Yeah.
Essential for not missing DH, but also not jumping to conclusions.
Absolutely. Clinical picture plus knowing the differentials guides your next steps.
Let's talk numbers then. How common is DH? Who gets it? What's the epidemiology?
Okay, so in the UK, the prevalence is estimated around 1 in 10,000.
So much rarer than coeliac itself.
They're much rare. Coeliac's about 1 in 100, remember? So yeah, while the link is strong, most people with coeliac don't get DH.
And when it does show up?
Typically adults. Usually kicks in between the 3rd and 4th decades, so 30s and 40s. It seems to be a bit more common in males than females.
Okay.
And geographically, it mainly affects people of Northern European descent.
So the sort of classic picture might be a middle-aged man, Northern European background, coming in with these symptoms.
That's definitely a high yield of profile to keep in mind. It's also noted that DH is probably underdiagnosed.
Meaning people suffer longer.
Yeah, leads to delays in getting the right diagnosis and that crucial dietary advice. Interestingly, the trend seems to be DH incidence maybe decreasing slightly, while coeliac diagnosis is rising, probably due to better coeliac awareness overall.
That makes sense. We're finding the underlying coeliac maybe earlier.
Could be, yeah.
All right, let's paint the picture. What does this actually look like and feel like for the patient? Key clinical features.
The absolute #1 symptom, intense itching, pruritus. Patients often describe it as unbearable, sometimes burning or stinging even before the rash appears.
Wow. And the rash itself?
Starts typically as small red bumps, papules, but they quickly turn into these tense, small blisters, vesicles.
And the distribution? Is it random?
No, and this is really characteristic. It's usually symmetrical. Think elbows, knees, back of the scalp, buttocks, shoulders sometimes. It loves the extensor surfaces, the outside bits of arms and legs.
Symmetrical extensor surfaces, elbows, knees.
And the lesions are often clustered together, grouped vesicles on a red base. They call it herpetiform because the grouping looks a bit like herpes clusters, but it's nothing to do with the herpes virus.
Okay. The name's about the look, not the cause. So, like you said, symmetrical patches on elbows and knees like little pads of itchy grouped blisters.
That's a great visual. Exactly that. Intensely itchy, symmetrical, grouped blisters, extensor surfaces. You'll often see scratches too, erosions and excoriations because the itch is just so bad.
Right.
The lesions tend to spread outwards. Severity varies. And it rarely clears up completely without treatment. And remember, gut symptoms might be totally absent.
Okay, let's try a quick mental checkpoint. Say a 45-year-old man comes in, unbearable itch, rash. You see symmetrical groups of small blisters, scratched areas, mainly on his elbows and knees, based on that itch, symmetry, grouping, location.
Yeah.
What's jumping out?
Yeah, dermatitis herpetiformis has got to be right at the top of your list. That combination is classic.
So suspicion is high.
Yeah.
How do you actually nail the diagnosis? What tests do you need?
Okay, the gold standard, the definitive test for DH itself, is a skin biopsy.
Right.
But how you take it is crucial. You need a punch biopsy, ideally from normal-looking skin right next to an active lesion, not from the blister itself as it might be too fragile or the key findings gone.
Perilesional skin.
Yeah.
And what are you looking for in that biopsy?
You send it for direct immunofluorescence, DIF, and you're looking for that pathognomonic finding, granular IgA deposition along the dermal-epidermal junction.
Granular IgA at the DE junction on DIF. that confirms the DM.
That confirms the skin diagnosis, yes.
Well, we know it's not just skin deep. What about investigating the underlying coeliac disease?
Absolutely essential. You must screen for coeliac. That means blood test serology, and in adults, usually a duodenal biopsy.
What blood tests specifically?
You're looking for the IgA antibodies. IgA anti-tissue transglutaminase, so IgA-TTG is the main one, or IgA endomysial antibodies, EMA. They're very specific and sensitive for untreated coeliac. Anti-gluten antibodies are pretty much outdated now for initial testing.
Okay, IgA-TTG or EMA, and then the biopsy.
Yes, in adults, even with positive bloods, a duodenal biopsy via endoscopy is generally needed to confirm the diagnosis. You look for those characteristic gut changes, villus atrophy, crypt hyperplasia.
Got it. Skin biopsy plus DIF for the rash. Bloods, TTG, EMA, plus duodenal biopsy for the coeliac. Any other routine bloods?
Yeah, it's standard to do a full blood count, maybe a blood film, check hematinics, B12, folate, ferritin, because the coeliac disease, even if silent, can cause malabsorption and deficiencies.
Makes sense.
And checking thyroid function, TFTs, is often wise too, given the association between DH, coeliac, and other autoimmune conditions like thyroid disease, maybe other autoimmune markers if needed.
Perfect. So it's a clear pathway. Suspect clinically confirmed skin with biopsy DIF, investigate underlying coeliac with serology, duodenal biopsy, check for related deficiency conditions.
Exactly. It's that two-pronged approach, skin and gut.
Okay, diagnosis confirmed. What's the plan? How do we actually treat DH and make the patient feel better?
Right. Management. The absolute cornerstone, the foundation, the long-term solution is a strict lifelong gluten-free diet. GFD.
Non-negotiable, basically.
Pretty much. It's the only thing that treats the root cause.
And why is the diet so critical? What does it actually do?
Well, it tackles the gluten trigger, obviously. Over time, this improves the skin symptoms, often dramatically. It reduces or even eliminates the need for medication. And crucially, it heals the gut damage from the coeliac disease, which is vital for preventing those long-term complications we need to talk about.
Okay, GFD is fundamental for the long haul. But that itch is terrible now. What about immediate relief?
Yeah, that's where meds come in, especially initially while you're waiting for the diet to kick in, which can take time, or if diet alone isn't quite enough. The first-line drug for rapid symptom control is Dapsone.
Ah, the third D. Dermatitis, diet, Dapsone.
Exactly. Dapsone works fast, usually gives significant relief from the itch and blisters within, say, 24 to 48 hours. It can be dramatic.
What that? There's a catch.
The big catch is that Dapsone only manages the skin symptoms. It does absolutely nothing for the underlying coeliac disease in the gut.
Right, and it needs careful monitoring, doesn't it?
Oh, absolutely. You can't just prescribe it and forget. Patients on Dapsone need regular blood tests. FBC, LFTs, UNEs looking out for side effects like hemolytic anemia or methemoglobinemia. Close monitoring is essential.
So rapid relief, but needs watching closely. Any alternatives if Dapsone is a problem?
Yes, sulfapyridine is mentioned as an alternative if someone can't tolerate Dapsone or it doesn't work well enough.
Okay, so pulling that together for management. If a patient has confirmed DH and coeliac, what's the single most important long-term strategy?
Strict gluten-free diet. Lifelong.
And the medication for quick symptom relief that needs monitoring.
That's Dapsone.
Great. So they're diagnosed, they start treatment. What's the outlook generally? What's the prognosis? Are they stuck with this forever?
With that strict GFD and good management, the prognosis is generally very good. Most people get significant symptom control.
But without treatment?
Without treatment, it tends to be a chronic relapsing condition. That severe itch can really impact quality of life.
How long does it actually take for the GFD to clear the skin? You mentioned Dapsone is fast, but the diet?
Yeah, this is key for managing expectations. The diet is slow. About 80% respond well, but it can take months. Even up to 4 years in some cases for the skin to fully clear just on diet alone.
4 years. Wow, that requires real commitment.
It absolutely does. But the payoff is controlling the condition, potentially stopping meds like Dapsone eventually. Many people on a strict GFD can slowly reduce and stop Dapsone over maybe 2 years or so, but the diet itself, that's forever.
So it's definitely a marathon, not a sprint when it comes to the diet.
Totally. Consistency is everything.
Okay, last key area. Complications, anything we need to worry about, either from the rash itself or the underlying coeliac.
Yes, definitely things to be aware of. From the skin, just the chronic scratching and the lesions themselves can lead to scarring or changes in skin pigmentation, hyperpigmentation.
Okay, makes sense visually. What about linked to the coeliac disease, especially if it was silent for a long time?
Right, and this really underscores why finding and managing the coeliac part is so vital. Untreated celiac disease carries risks. Neurological problems, things like ataxia, peripheral neuropathy, even epilepsy have been linked.
Serious stuff.
Yeah. Cardiac issues like pericarditis or cardiomyopathy. Bone health is a big one, osteoporosis due to malabsorption,
Yeah.
and dental enamel defects, too.
Quite a list. Anything else?
Well, there's an increased risk of things like aphthous mouth ulcers, and the one people worry about, certain types of lymphoma, especially small bowel lymphoma.
Okay, good.
But, and this is really important, that lymphoma risk, which is mainly linked to severe gut involvement, decreases significantly once someone is strictly following a gluten-free diet.
So that list of potential complications is a massive motivator for sticking to the GFD, beyond just controlling the rash.
Absolutely. Diagnosing DH isn't just about the skin. It's often the gateway to identifying coeliac disease, a systemic condition needing lifelong management to prevent these serious outcomes. The rash is the clue.
It really highlights that connection, doesn't it? Gut and skin linked by the immune system.
It's a classic example. Diagnosis and management of DH and coeliac really go hand in hand.
Okay, well that feels like a pretty thorough deep dive into dermatitis herpetiformis. We've hit the definition: autoimmune, itchy blisters, IgA, coeliac link.
The 80% stat for coeliac changes.
Right. The diagnosis, skin biopsy with that granular IgA on immunofluorescence, plus the coeliac workup. Management GFD is king. Dapsone helps the itch, but needs monitoring.
And remembering the prognosis is good with the diet, but it takes time. And the potential complications mainly stem from untreated coeliac.
A great reminder, really, to always think systemically. An itchy rash might be pointing to something much bigger.
Exactly. Look beyond the surface symptom. It could unlock a diagnosis with major implications needing lifelong care.
For more free MSRA revision resources, visit freemsra.com, and for the full premium revision toolkit, head to pastthemsra.com.